So this is decisions. This is about a session really about how we make clinical decisions in clinical practice, particularly in ICU. And I will use examples of the common decisions that are currently made on ICU and maybe how they're made, and try to link things really through to some of the psychology around and how these decisions can possibly go astray, go a bit wrong, and we can end up making bad decisions. And then maybe touch on the sort of things that we should be doing to minimize that risk, and make sure that's introduced into our clinical practice. I hope that some of the things that I say might surprise you, and some of them will be, oh yeah, not that again. So hopefully it'll be a bit of a mixed bag. This is the second in a series of non-clinical related sessions that I've done. I did one about 6 months ago on getting sort of ideas off the ground and how you get those into practice. So this is kind of the second in a series of sort of clinical management-y type things. So I hope it's a benefit to you, and feel free to ask any questions. And what I'll do is, when I've finished, is wander around and see if you've got any questions. I'd like it to be participatory, and there'll be some aspects that I will be looking for some kind of interaction, and you can do that by raising your hands, because there'll be sort of straw polls as we go through the session. So yeah, without further ado, I'll crack on. I think if you are post-fellowship, and certainly you are working towards, a senior clinical role, possibly as a consultant within the trust, or anywhere, an absolutely essential text to read, I think, is this book called Thinking Fast and Slow by Daniel Kahneman. And it's been around for about 10 years, and it's a really it really shows how our thought processes can go wrong, and how vulnerable we are to getting things wrong. And a lot of what I'm going to talk about today is drawn from this text, and I've tried to link it to clinical examples. So I would impress on anyone that is now post-exam, perhaps working towards getting a consultant job, and taking on more and more clinical decisions, that this is essential in your reading. And I'm not going to be able to show you everything that's in the book. This is very much an introduction to what it says. So this is something that I think everybody should read. The other text I mentioned there is about the power of intuitive thinking, which comes towards the end of the presentation, and it's a book called Blink by Malcolm Gladwell. He's written a great series of books actually on psychology and social psychology that are all worth a read. But that's a good text to read as well, but not as essential as Thinking Fast and Slow. So if you read one book, it's that one. Okay. So a little bit, some brief stuff now about how we think, and the process involved. And this is sort of commonly held psychology about how we think, make decisions about the world around us. So broadly speaking, it's broken down into two systems, and what's known as System 1 and System 2. System 1 is essentially, you almost don't know it's happening. It's very rapid, effortless. You're not even thinking about it. It's generally intuitive, automatic, involuntary, and actually believes everything that it sees in front of it. Okay, so it's quite concerning that the brain works like this, but it believes everything for at least for a split second that's in front of it. It's constantly scanning the environment and looking for opportunities and threats, and it's kind of embryonically or evolutionary It kind of evolved from spotting predators in the bushes, so that you're not going to get eaten by a lion, and if necessary, take evasive action. So it's kind of that automatic thinking that's going on in the background that's keeping you safe, and looking out for any tasty morsels that might be there to eat as you go along on any other treats. It can, as I say, it's automatic. You don't really have a great deal of control over it potentially. But people in elite areas like chess or in elite sports, or anyone who's highly trained in a particular area, can enhance their system one thinking to spot certain things. So yeah, that's there. So that's the first thing. And then system two is more the analytical systems in your brain. So it's much slower. It requires a lot of effort at times. Analyzes and processes and questions things. To really work it, you have to consciously engage it. So system one will usually pick up that something's happened and then pass it to system two to look at it in more depth. Now, the fundamental problem about system two is that it is inherently lazy. What that means is it's not really interested in spending too much effort if it can get away with it, and will look for the simplest way to solve a task. And as we'll see, that can cause problems for us. So a lot of what we're going to talk about now is how system one and system two interact, and how we can accidentally, if you like, make decisions that have been drawn straight out of system one, which are all completely intuitive and unquestioning, and obviously then things can go wrong, or the lazy system two, not engaging fully and actually getting led astray and not making the right choices. Okay, so that is fundamentally how we're structured, and it is prone to problems. So as I say, system one is about keeping us safe and doing intuitive things. You can train it. That's Novak Djokovic there, and he's an elite athlete, and will often have to receive a serve at over 100 miles an hour. He doesn't have time to think. He will almost always use system one to essentially do the nuts and bolts of playing tennis, and he'll leave his system two actually to be thinking about tactics and the weakness of his opponent. So that part of his brain is almost completely disengaged. If you were to ask him how he played an amazing stroke, he probably wouldn't be able to tell you, because it's all just done intuitively. So system two, as I said, this is where analytical thinking tends to happen. But the sort of things that can cause system two almost to be switched down or turned off are a couple of things. So the first, if, for example, there's cognitive load going on, so it's occupied doing something else, then if you give it another task to do, it probably won't do that task very well. So using a mobile phone while driving is a classic example where you're trying to do two tasks and one of them won't be done particularly well. But if you were asked, for example, while you're trying to intubate somebody, whether or not the patient in bed 15 could be discharged, that too might cause a problem. HALT. So this is banded around. This is an acronym for hungry, angry, late, and tired, and it's often used in medical circles of when not to make big decisions, and that's because it switches off system two. Okay, and then there's the opposite end of the scale. So there's something called cognitive ease. So cognitive ease essentially means when you're actually quite comfortable, happy, everything's easy, whatever you're reading is the text is really easy. It's really easy to digest, and you get lured into a false sense of security and lured into making intuitive judgments. So essentially, System 2 doesn't switch on because it doesn't think it needs to, because the world is just a nice, easy place. And I think that's something we forget often, that if we're having to make what seems like a really easy decision, everything is presented to us, we might take shortcuts. So the word heuristics here, I mean, it might be a term that you're not familiar with. This essentially, that means it is the shortcuts that I'm talking about. So and heuristic is a simplified rule of thumb, a shortcut that System 2 might use to solve a problem that might make some inaccurate assumptions about what's going on and lead to a form of bias in a decision, and inevitably the wrong call. And we'll be talking a lot about heuristics going forward now. Okay, so what I want to do now is try and link some of the decisions that some members of the senior medical team, senior trainees might have to make during a day on ICU, and maybe look at how those things could go awry. So I've picked out a few of the big ones in a day. So the first one is, do we actually have a bed, say for an elective? How do we make that decision? The other really big one is admissions, and an unplanned admission. Will that patient actually benefit from admission to ITU? How do we make that call? Diagnoses, how do we get to making diagnoses, and how that might how there might be pitfalls there. Interpreting physiological measurements and blood results, how can go awry. Decisions around withdrawing support, I know another really big decision, and decisions around fitness for discharge. Okay, so we use those as examples of where we might be going. Okay, so the first one is about, do we have a bed? So to frame this, we would always be thinking, an intensive care unit should always have the capability to admit someone who needs to come in an emergency. That's the fundamental safe thing to do. Okay, so if you can't do that, then that can cause potential real harm to patients if someone needs to come to ITU for treatment immediately and they can't come. That could cause a serious incident, cause serious harm to a patient, and that is what we're fundamentally trying to avoid. So we should always try to have at least one bed. Coupled with that, every morning we will often have a number of scheduled elective cases that need to come to ITU post-op. So they're planned to come. So it's a planned rather than unplanned admissions. Okay. And if we were to admit all those patients, would that lead to a situation where we don't have a bed? As we know, in the UK, in Leicester, we tend to run all of our intensive care units close to completely full. So capacity for emergency admissions, if we're admitting loads of electives, could be compromised. So there is a fundamental decision to be made. Do we have to cancel those elective admissions in order to maintain the ability to admit an emergency? So it's a really tough decision to make. Okay. And there'll be lots and lots of potential things that influence the state of our beds. So the circle in the middle, as you well know, our intensive care unit has a fixed physical number of beds, some of which will be occupied by patients, and their acuity might be HDU or ITU, and that will determine the amount of nursing that's required for them. There may be infection prevention issues which will require side rooms, and they may or may not be full. You then, alongside that, have the actual effective number of beds, and that would be dependent on the number of nurses on each shift, which may vary, and the experience of those nurses as well. So within that circle, there are several variables that you first have to consider regarding whether or not we have an empty bed to admit an elective into and still have an emergency bed. So from there will at any particular day, there will be a number of patients that are maybe well enough to go to a ward and may be waiting for such a bed. There'll be some patients that die at the LRI. That is usually in the region of about 2 to 3 patients a week, so not usually every day, and rarely there might be transfers to another site or to another hospital. On the other side of the equation, as I mentioned, there will be a series of elective cases, all with designated probable levels of priority in terms of whether they're cancer or not, whether they've been previously cancelled, etc. There'll also be emergencies, and they can be surgical or medical, coming from various different places like ED, acute medical wards, or from theatres. And there may be patients needed to be transferred into the site at different levels of urgency, or even repatriations from other countries. So all of these things will need to be considered. And the thing about all of this is that each and every one of those individual components, probably not the number of physical beds, but everything else is dynamic. So it changes probably every hour at least. So patients that you thought were getting better on the ITU and going to the ward suddenly can't. Some might be getting better. A nurse could phone in sick. An elective that was going to come, it doesn't need to come. An emergency appears out of nowhere in A&E, and so on. So in a nutshell, when we try to decide whether we got a bed or not, it's nigh on impossible to accurately predict if we know for sure a bed is available, with absolute certainty. So essentially, I mean, what we almost have to do is to work out a level of probability with all of those particular inputs and outputs on our unit. What is the probability of each of these things happening as predicted, and a probability that we might not have a bed? And the probability of not having a bed could range from anything from 0% on a really, really good day where nothing much is happening, to almost 100% if we're in a state of crisis with, like a COVID pandemic or something. So what I'd like to do now as an exercise for all of you is to see what the threshold is for where you might cancel an elective. So I can see you all in the room. So what I'm going to do is start counting from 0 to 100 in 5% chunks. Okay, so we've looked at all of the parameters and variables and everything that are potentially influencing a bed, and the probability of there not being an emergency bed. Okay. And what I want you to do is, when I get to that probability of there not being an emergency bed to admit someone into, I want you to raise your hand to say that you will cancel the elective. Is that clear? Yeah. Okay. 0%. 0. 5%. 10%. 10% risk of not having an emergency bed. 15%. 20%. 25%. Oh, there's a hand up. Oh, it's down. Yeah, okay, up or down. So we've got one hand up. Okay, so that's a 1 in 4 chance of there not being an emergency bed. Okay, 30%. 35. 40. God, you're brave. 45. 50. Oh, 50%. So it's a flip of a coin. 50%. 55. 60. 65. 70. 75. Okay. And Mike Little's hand's gone up as well on the Teams. Thank you, Mike. 80. Is that everyone, by the way? Almost. 85. 90. 100%. So yeah, I think everyone went up between, someone went up at 25 and a couple then at 50, and then most around the 75 mark. Okay, thanks for doing that. Okay, so I mean, as you can see there, we all have probably slightly different thresholds of how we interpret risk, of that potential. And of course, the equation is never quite as simple as that. And as you'll see, I've only given you half the story. So we might do the exercise again in a minute. Okay, so there are two sides to every story. And what we haven't heard here is really anything about the risk on the other side of the coin. So, obviously it's a silly thing to say, but elective patients are patients. They're people with stories, and when we are all there focused in intensive care about intensive care beds, it's very easy to forget about these people and their stories. They will often have cancer, severe heart disease, or an aneurysm, or something like that necessitates the major surgery that they need. And cancelling and delaying them is an extremely big deal, and it's a big deal for a number of different reasons. The first is that when we know this from the pandemic, there is a physical risk to the patient. So their cancer could progress while they've been postponed or cancelled to become inoperable. Somewhere between 10 and 20% of patients with cancer that were delayed 3 months plus during the pandemic became inoperable. Patients may burst their aneurysm, have a massive MI if they're waiting for heart surgery. All of these things could be life-threatening. So there is a huge potential risk to our patient population that get cancelled, not to mention building themselves up to come in for this major surgery only for someone to say that it's been cancelled. That is going to cause huge psychological impact to patients. And we would potentially forget that patient then will have to be rescheduled somewhere else, which will cause a domino effect of knocking on somebody else to be probably postponed to another date, and so on and so on. So this will potentially precipitate a bit of a domino effect. When you've got 8 million people waiting for surgery in this country, that is a big deal. There will, particularly our surgeon, I think the anaesthetist I might put maybe in parentheses, but the surgeon will be psychologic prep to do a major operation, and having that plan taken away from them will have a big psychological effect. Having a theatre potentially running much less efficiently due to the cancellation, or even standing empty, will have a huge financial impact. So the other side of the coin is really quite important for us to maintain in our thoughts, and perhaps take risks at a higher level, because we may actually be causing risk to other patients. Okay, and this is a really important principle, a heuristic that we can overlook, and it's probably the most important one in decision making in medicine. So I think what I might do now is do that exercise again. So major surgery, someone's an elective is scheduled, let's say for a gastrectomy, and we are doing the same exercise again in terms of risk. So potential chance that we don't have an emergency bed, knowing of course that there's always a contingency plan. There'll always be PACU or somewhere that we can utilize somehow. So actually, when you think about it, the number of times we haven't had a bed, I can't think of it. The reality is it's really rare not to happen that we don't have an emergency bed to admit into, isn't it? So with that in mind, and with what I've just said in mind about our patients waiting, let's go for the exercise again. 5%, 10, 20, 30. Oh, Dinesh is on at 30, 40, 50, 60, 70, 80, 80%. Mike Little's in at 80%, 90, 100. Oh, and then hands are waving at 100. So I think it went up a little bit there. I know I sort of biased it slightly, but it did go up a bit. Okay. So this is heuristic mentioned in Daniel Kahneman's book, and as I say, it's the most important one, and it's called "What You See Is All There Is." And things like confirmation bias come into this in a degree, and it's shortened into the acronym of WYSIATI. Okay, and all that essentially means is that if you don't spend the time thinking about the things that you don't see, you don't know, the two sides to a story, etc., if you're not fully informed about what's going on, every angle of a story, then you might make a judgment that is maybe misguided. Okay, so we'll come back to WYSIATI in a minute, but it's really important to try to be balanced based on the information from all angles. That's what this is saying. Okay. So what about admissions? So will a patient benefit from admission to ITU? I haven't got a clinical example on this for obvious reasons, because I think we need to look across a spectrum. First off, what I would say is talk about outcome of that decision. And there are three possible answers to that question when you referred a patient maybe from an acute medical ward with someone with severe debility, who's maybe very frail, very old, with a very serious illness, and that can be that they don't benefit. They might benefit, we're not sure, we might need more information, we might need to see how they respond to treatment, or yes, absolutely, they do benefit. And then really between each of those, as all of our trainees I'm sure will recognise, each consultant within the intensive care community probably makes slightly different judgments, and around each of those kind of boundaries between maybe no and maybe to yes, there may be some blurring of that line where there's a bit either side, where consultants maybe make slightly variable decisions, and that phenomena is called noise. And when there is a very noisy system, maybe where there's a lot of variation, that is something that we should really need to know about and need to audit. But I would say that certainly I would say at the LRI, I think that there is probably a level of consensus, but there is also a bit of noise, and there has to be, I'm afraid, around every of these potential boundaries of decisions. So in terms of outcomes, the way that this would sway is that no, if they're not suitable, then that will be the recommendation to the team, that they wouldn't benefit from coming to ICU and ward-based care only. maybe is a difficult one, and is quite a common one actually these days. And in that situation, it might require the gleaning of further information, or just to admit the patient to ICU for a trial of therapy over a designated period of time and look for a response to treatment. And then yes, it's a no-brainer, bring them in as soon as possible, and crack on with treatment. Okay, so let's move this forward. So when you're sort of approaching that situation of trying to find get to a decision, there are a few things around what you see is all there is, or Ricciati. And the first one is around acute deterioration. So on the left-hand side of this chart, it's a two-dimensional thought process here about what sort of things we might do for patients of varying levels of comorbidity and frailty when they deteriorate. Okay, so on the y-axis there, I want you to focus on the kind of markers of deterioration. This trust and the NHS in general is set up as News 2 as the primary marker of deterioration. And most of the time, it works. People with high news scores tend to be deteriorated and need our attention. And that's how all our alerts system works. And even DART use the phrase newsing to someone that's maybe deteriorating. And that's fine. But, you know, the research suggests that, yeah, it'll successfully identify a deteriorating patient about 70% of the time. But that's not everyone. And that's you know, and the data that we've recently been collecting from the current Sequin suggests that only about half of all of our unplanned emergency admissions to ICU at the Royal, and actually across UHL, only about half of them have a news of 5 or more, which is the standard sort of trigger point for someone that's deteriorating. So that's not all the story, and if that's all you use to look for deterioration, and we've had problems in the past with this, then patients could present late or be delayed in their admission to ICU. So there are other markers of deterioration that we have to be mindful of. AKI is an independent marker of deterioration. The problem with it is that it's usually only measured once a day if you're lucky. So you don't really get a continuous process there, but it could flag up sick patients. Something that's very in the news at the moment is concern, particularly concern expressed from families. And that's something that is being increased and rolled out across the trust as something called Call for Concern, where actually patients' relatives can contact the outreach service directly to say that they're concerned about deterioration. But that concern could also come from staff members, that, you know, the patient hasn't got a high news, but I'm really concerned about them. You know, that's something that is very, very relevant. And the third one that I've listed there is oxygen requirement. And this is something that we saw a lot of during COVID. And in fact, there was an NHS England alert on this that essentially said that patients were deteriorating or even dying on wards because their news score wasn't going up, but they were clearly getting far, far worse with their COVID because they were needing more and more and more and more oxygen. And that wasn't necessarily flagging up on people's alert systems or in their consciousness that they were getting much worse. So the first thing is markers of deterioration. We shouldn't be over reliant on news scores. Okay, so that I guess that's first. Now, alongside that is around the decision to admit. So most of us will, be fully familiar with this kind of process, but we have to go through an investigative kind of process, looking at clinical evidence of the patient, primary care records, secondary care records, really an in-depth investigation, talking to relatives to try to ascertain and quantify things like frailty, comorbidity and functional limitation. And broadly speaking, that ends up being mild, moderate or severe. When it's severe, I think most of us would feel that admission to an intensive care environment would not necessarily be beneficial unless the patient had some kind of rapidly reversible critical illness pathology, like a band adhesion. That's the thing that I can think of easiest. So that sort of patient group we probably wouldn't admit. And then on the other end of the scale, patients that are very none or mild frailty, comorbidity, or limitation, we should almost expedite them to our service, because there shouldn't be much of a decision about their potential to benefit. Then there's the group in the middle that are the we're not sure group, and as I said earlier about the outcome decision that we have to make, that could be an admission to ICU for a trial period, but probably only after a proper discussions had between maybe the home team or the family of the patient to clarify their functional state, patient's wishes, respect, etc., and what kind of escalation plan we would enact, and if as they deteriorated, then to enact that really, and possibly admit them or not. What I'm saying is that Rossetti can come in two different ways, either for missing acute deterioration, or not properly quantifying, or getting wrong through misinformation the frailty or comorbidity or functional state of a patient. And we've been caught out a few times on both sides of the equation, where patients have been admitted to ITU and we've discovered actually they're incredibly frail, but also patients that maybe we've declined and then found out actually they're much better than was first found, and later had to reverse the decision and admit them. So I think this equation goes in both directions. And it is something, unless we invested our system too properly into this, we could make a bad decision. Okay, got another one here in terms of audience participation, and this the information here is deliberately scant. Okay, so don't ask me for any more than there's already on there. So we are called about an admission to the emergency department with acute onset severe breathlessness, right-sided pleuritic pain, and has come in from home, high respiratory rate, low saturations, and has now become oxygen dependent. We know that they're recently immobilized in bed at home for the past week due to a back injury. They're moderately obese. So that's a sort of potted story that we have. Not very much information, I know, but what I want you to do is go out there and speculate what you think the most likely diagnosis is. So let me just get my screen big. So hands up if you think it's a pulmonary embolus. 1, 2, 3, 4. Okay, that looks a big chunk. Hands up if you think it's a pneumonia. Mike Little. Okay, you're on your own, Mike.
Not the first time.
Okay, so there seemed to be pulmonary embolus was the most likely diagnosis. So any ideas in terms of presentation to the emergency department, what how many patients come in with a PE, diagnosed PE, and how many come in with a pneumonia? Anyone want to venture a guess?
10 to what?
So yeah, so about 0.1% of ED attendances have a PE, and about 5% have a pneumonia. So just on base rates alone, you're 50 times more likely to have a pneumonia. So if I was to say that presentation there is deliberately generic, and it's deliberately made, it could equally fit for either of those diagnoses, and yet one is 50 times more likely than the other. Is anyone like to change their vote from one way to the other? So does anyone think it's a pulmonary embolus? Hands up if you think it's still a PE. Oh, couple. Who thinks of pneumonia? So yeah, so you're 50 times more likely to have a pneumonia than a PE. I mean, this is not an uncommon thing, is it? You know, the number of patients that come into ED and get what we would call heparofruticillin, or you know, an anticoagulant, an antibiotic, and a diuretic that are breathless, and all of those treatments, if they're given incorrectly, will cause potential harm. So yeah, this is an important exercise, really, in kind of thinking, because base rates are so important in the actual frequency that things could happen. So let me take this a bit further. Yeah, so
John, can I ask a question?
yeah.
Ultimately,
Mike.
we don't look at the base rates, though. We ultimately look
No.
at the patient in front of us.
We do.
And we don't know how many of those 50 presentations to ED with PEs or pneumonias have already happened. So it's it'll be lovely if we worked like that, but
no, you're right. No, you're okay. But I think you know, this I could have used a slightly different example. A patient that we had in room 2 a few weeks ago was considered for rickettsial disease, but who had a group B strep. But no, I just wanted to emphasize, you know, the importance of us being aware of what the base rates are, so that we don't miss the common things. Okay, so yes, it would be it might be a completely right thing to maybe send this patient for a CTPA and give them anticoagulation. But in terms of probability of presenting to ED, it's still extremely likely that the patient has a pneumonia, and I think we should always be mindful of that. An unusual presentation of a common pathology is still more likely than the common presentation of a rare one. Okay. Another heuristic and bias that we can have, and this is something that I've seen when we do mock exams. This is quite fun, and I think anyone that's an examiner probably sees this, is substitution. So our brains, our system 2, inherently wants to simplify the world around us and wants to answer a simpler question to the question that's asked. Okay, so for example, the patient with septic shock coming into ITU, will this patient benefit from ITU? We might simplify that to, will their blood pressure go up with noradrenaline? And obviously that's a different question, and you know, our brains will naturally try to simplify complex situations into simple questions that we can easily answer. That's the natural thing. And so many times I've been asking questions in Vivas, and you ask a question and the candidate answers a different question that's much simpler, and I think that's just their brains trying to solve, you know, trying to solve a simpler question, and just using their system 2 in the right way. Okay, so substitution and answering an easier question. Halo and inverse halo effects, I guess that's fairly easy to describe. So essentially a halo effect is that, you know, so something or someone looks really good, and then you translate that really goodness into being really good at everything, and clearly that may not necessarily be the truth. Regression to the mean, obviously this is anyone involved in research, as we all are, or analysing research will know. And I guess could I give an example of that? Well, a few years ago, a single centre study came out advocating the use of vitamin C in patients with sepsis, that it would halve mortality or something stupid like that. And we all thought, yeah, this could be great. And then, of course, the big multi-centre studies were done, and actually we just found that the trial that had showed that benefit probably just got lucky, or they had some nuanced aspect to it, or bias in it that just made it look really good. And actually, when we did repeated this multiple times, the effect disappeared. So we can see that a lot in single centre studies and research. Another really interesting heuristic and associated bias is something called anchoring. Now, the best example I can give of that is, again, when we think about nerve centre, actually, and patient's blood pressure. So imagine a patient coming in hypotensive. So we naturally think of systolic blood pressure being around about 120 to 140 systolic as sort of the normal. So we're all sort of wired in terms of our systems to think 90 or less is bad. So when someone comes in with a blood pressure of 89, we anchor that to a normal of 120, 140 and think, oh my God, that's not very good. Now, obviously, if that patient happens to be, say, a young female patient who walks around with a normal blood pressure of 95 systolic, then the difference between 95 and 89 is tiny, and we would have a very different opinion of that. However, that patient's blood pressure that's normally 95, when you put their OBS into nerve centre, it will scream at you with an EWS of 3 on blood pressure that you need to do something about it. And the possibly other staff members across the trust might do the same, and you almost have to resist the process. And the opposite's true as well. So the severely hypertensive patient whose normal blood pressure, say, is 180, if you put and their blood pressure is now 110 systolic, it will hardly alert at all, but there could be something very seriously going on with that patient. So anchoring is a potential, and that can happen for things like serum creatinine or any other physiological measurement that you could get anchored in the wrong way. And almost you can move your anchor. So if you're in theatre and your patient's been hypotensive for a very, very long time, you almost kind of get used to it. And then it's only when somebody else walks into the theatre and realizes, hang on, this is really low, potentially, that you go, oh yeah, so it is. So these things can be quite dynamic as well. Of course, it's most important when you're buying a house, because it's probably when the price of the house is told to you, you kind of anchor towards that. If you didn't know what the price of the house was, you would probably think it was much cheaper than it was. Anyway. So withdrawing support, and actually we're going through this process on the ITU at the moment. This is again a really big decision to get right. So it's really important that we all have our system 2s engaged, and that we are thinking completely logically about things. So how do we do that? Well, more than one person, not rushing to a decision, and a little bit like GPS identifies where you're on the planet, where about 4 or 5 different satellites point at you and triangulate your location. We should do the same thing with the information that we have to hand. And classically, the situation of someone that comes in severely brain injured to our unit, and we're thinking about withdrawing support, we usually have 3 different pieces of information to hand. that we would utilise, and that's the clinical consciousness and assessment of the patient at the bedside, usually some imaging like a CT or an MRI, and usually say an EEG. Now, if all of those things point in the same direction, showing conclusively what is going on, then you can be a lot more certain about things. I certainly, over the past 20 odd years, have been caught out. I've had CTs reporting a patient to be imminently coning, only for them to wake up and leave the unit 2 days later. You know, so I think it's really important when you're making the big decisions to, as I say, triangulate from multiple sources to get the information right, and only move forward when it's all pointing in the right direction at the same point. And if there's any inconsistency, I think we need to spend more time working out what's going on. So that's one way, one of the tools that we can use, maybe to make sure that we don't make bad decisions. Can he go to the ward? There we go. So again, another really big decision to be made. You know, patients discharged from ITU to a ward that end up bouncing back, coming back to have a pretty poor prognosis. So sending patients back too soon is risky, and it's very easy to get caught out. The cognitive ease side of things can kick in here. So you walk to the patient. He looks fine. He's laughing and joking with you. The end of the bed looks fine. We're tight on the unit. There's a bed for him on the ward. You know, why not just send him? But you know, there could be issues lurking, and that's why we should always stop and just make sure we engage our system too. How do we do that? Well, this is where things like checklists and LOCSIPs come in very handy, because they do structurally engage your system too. The WHO Safer Surgical Checklist is there primarily to engage you and make sure, try to make sure that there aren't sort of hidden risks lurking in the background. And it's the same with this guy. So he looks fine, but then when you chat to him, he thinks you're Rishi Sunak and you're coming to shut down the unit and sack all the nurses, and he thinks that's hilarious. You glimpse the monitor and you see little flickers of AF, and in fact the Ivor Lewis that he had 5 days ago, the anastomosis is just starting to peel apart and pus is dripping into his mediastinum, and in fact he shouldn't be going to the ward. He should be staying and having a scan. So we should be doing structured things to minimize these things. About 7 or 8 years ago, LRI, after a series of M&M meetings where we had a number of patients that were readmitted to ITU or died on the wards, we identified a series of reasons why that might be happening, and we came up with an acronym called AEIOU, which I know I've been banging on about all this week on the unit, but is essentially a discharge safety checklist, going through all the important things. So whether they've got agitation or delirium, what's their EWS, any investigations or interventions that are worrying, are they off organ support for more than 24 hours, uncomfortable, are their pain management and usual medications back on. So you know, going through something like that to assist you in your system too, being logical, is really important. It's really, I guess it's a good idea to talk through scoring systems a little bit, just superficially. In Kahneman's book, they wax lyrical about these types of things, because again, they're a good way of engaging system 2 in a logical way and making sure that the human brain doesn't forget things. And so are potentially very useful, particularly when so there's staff that are of an intermediate or low level of experience, and scoring systems are growing at a prolific rate. There's a new one every week. I've listed a few there, and of a variable use. some of them are better than others, and about 30 years ago, when Apache first came out, an intensivist in London thought it'd be a great idea to use Apache 2 as the decision process for whether a patient should come to ITU or not. That ended very badly, and I think the consultant involved ended up having to leave the country. Since then, we haven't done that. Having said that, I think in the dark days of the pandemic, when there may have been a need for rationing intensive care services, there was a suggestion that SOFA scores might be used to determine admission to ITU as an objective, non-human way of doing it. And again, I think most of us felt very frightened by that prospect. But anyway, I mean, the thing about scoring systems generally, as my experience of them personally, is that they can not be greatly useful. And essentially what they often do is give you a percentage risk, such as a percentage mortality risk, and essentially put the patient in front of you into a subpopulation with that risk. You don't know if actually their risk is higher than that. Within that population, there may be other factors about them that the scoring system hasn't taken into account that makes their risk higher. And as an experienced clinician, you might actually be able to quantify that. So it might put you in the right sort of ballpark for percentage risk for patients using scoring systems, but I wouldn't use it fundamentally to decide what to do with individual patients, but it might help frame conversations, it might help frame thinking. And the other thing about scoring systems, they usually land in the middle, so in that not sure aspect, so you end up having to do what you're going to do anyway. So yeah, mixed feelings about scoring systems, but potentially very useful about framing a situation. Intuitive thinking. So this is obviously system 1 driven, and this is something that is a really interesting subject, and I think that book that I mentioned at the start, Blink by Malcolm Gladwell, goes into this in a much more depth. And essentially what it's about is the power of intuition is pattern recognition. So situations we've seen before, if you have no patterns to recognize, so in other words, relatively inexperienced, this is an extremely dangerous thing to do, because you're essentially shortcutting all of your thought processes and flying on the seat of your pants, and just making decisions with very low levels of mental processing. And generally speaking, that is not a good idea. But intuitive thinking is powerful in certain situations, and that's when it's being made by a highly trained, experienced individual. The 10,000 hour rule applies in terms of expertise, and I did a rough back of a fact packet calculation that probably equates to being a consultant for somewhere between 5 and 10 years. That's when intuition may come into play, where you've seen situations before many times. It's in an environment that is regular or predictable. Kahneman says in his book that a hospital environment on a ward is such an environment. What isn't such an environment is the stock market. And that those processes and decisions, there is continuous feedback for and development of that decision-making process. So if those sorts of things are in play, then intuitive thinking is potentially useful and accurate, but is caveated by the fact that it may mean that system 2 is switched off, which is risky. And I would always say that we should always back up our decisions by having a good thought process. But it could initiate, an appropriate line of treatment or or you get treatment started much quicker than it would be otherwise. So yeah, I think it does have a role to play, but only in the circumstances I've said. There are a few certainties in medical practice, or probably none, but the only one that is close to certain is when we carry out 2 sets of properly conducted brainstem function tests to diagnose death. That's probably as close to a certainty that we can get, and even that's probably 99.99 recurring. So otherwise, decisions are probably going to be made on the basis of probability, and no matter how good and how balanced a decision we make, sometimes these will be wrong. As long as they're using sound logic, but there can still be patient harm. And I guess what we have to have in this situation is when we've made a decision and it's turned out to be wrong, is that there needs to be the right culture behind us to make sure that there's support, learning is looked for, and there is the right involvement of patients and their families. And you could argue that this, over the years, that the NHS has been very variable in how we've approached this. You know, some notable individuals have ended up in prison because of this, and it shouldn't have done. And I think the direction of travel we're now into is something called PSIRF, which is Patient Safety Incident Response Framework. These 3 issues that I've mentioned are first and foremost in this new direction of travel in patient safety within the NHS and within UHL particularly. You'll be seeing more about PSIRF and this safety culture that's evolving in the coming months. I think you'll see it everywhere. And I do hope this helps change things. You will no longer hopefully be demanded to have statements and interrogated. There will be what are called discovery interviews instead, to try to work out what happened and look for learning. And that's the fundamental difference here. I think with the old serious incident investigations, trying to get down to root causes, there was often the potential for the finger of blame to come out, and that is not what should be happening. Okay. So just summarising really what we've gone through. Thinking is about 2 systems. System 1, which is intuitive, effortless, fast, but prone to jumping to conclusions. System 2 is analytical and measured, but inherently lazy. So we have to think hard about making sure we engage System 2 properly when we're making important decisions. System 1 can get accidentally switched on when we're hungry, angry, late, or tired, or when System 2 is engaged doing something else. But also, if we're happy, comfortable, or things are easy, then we can accidentally make System 1 decisions. What you see is all there is. WYSIATI results from the full picture is not there and being neglected, and it leads to a biased decision. Errors in decision-making tools, through tools such as checklists and scoring systems, etc. Just mean you just take a second and just think about things before making a decision. Intuitive thinking really should only be made by highly experienced staff in a stable environment, and really properly backed up afterwards by proper System 2 thought and checking.